If you walk into literally any intensive care unit right now, you are you're immediately surrounded by some of the most expensive, highly engineered technology on the planet.
Oh, absolutely. It looks like a spaceship in there.
Right. I mean, you'll see million-dollar ventilators breathing for people, experimental dialysis machines filtering blood, and these crazy IV pumps delivering highly toxic, life-saving drugs just, drop by drop.
Yeah, and you naturally assume the danger in that room scales with the complexity of the machines.
Exactly. But the device responsible for one of the most massive, unkillable infection risks in that entire hospital, it isn't even plugged into the wall. It's a $3 piece of flexible tubing.
It really is.
So today we're doing a deep dive into the urinary catheter. Welcome, everyone. We're going to look beyond all the clinical jargon of insertion and care to uncover this fascinating story about infection, hospital economics, and honestly, a massive shift in how we think about the human body.
Because it really is the perfect blind spot in modern medicine. We have this deep-seated instinct to blame catastrophic outcomes on complex failures,
Right.
But the history of the urinary catheter shows us something entirely different. The greatest risk to a patient usually isn't the hardware itself, it's the human decisions.
The human decisions, right.
Yeah, the medical dogmas and just the sheer psychological momentum of how we manage that hardware on a daily basis.
Okay, let's unpack this.
Yeah.
Because when most of us hear the word catheter, we tense up a bit and we just lump everything into one very uncomfortable mental bucket.
Oh, for sure. Nobody wants to think about it.
No, they don't.
Yeah.
But to understand the stakes here, we have to separate them out. Because there are four main types, and they interact with your body in wildly different ways. First, you have the indwelling, or Foley catheter.
Right, the one most people are thinking of.
Exactly. That one goes up into the bladder and just stays there for hours, days, or even weeks. Second is the intermittent catheter, which is strictly an in and out situation. Inserted just to drain the bladder and immediately removed.
It's just temporary fix.
Yeah. Third is the external catheter, commonly called a Texas or condom catheter. That one is worn over the penis rather than inserted inside. And finally, the suprapubic catheter, which bypasses the urethra entirely and goes straight through the lower abdomen into the bladder through a surgical incision.
And the distinction you just made, that is where so much of the confusion begins. Because while they all technically do the exact same job,
Draining urine.
draining urine, right, but the biological consequences depend entirely on how long they stay in contact with the body.
Okay.
Yeah, duration is the invisible threat here. And to really grasp why we handle these devices the way we do today, we have to look at how two vastly different medical philosophies collided over the last century.
It's basically a tug of war between adding hardware and taking it away. And the story really kicks off with the addition side of things.
Back in the early 20th century.
Right. Between 1929 and 1935, a urologist in Minneapolis named Frederick Foley came up with what we now call the Foley catheter. And looking at what he was trying to solve, his design was honestly brilliant.
It was a game changer, really, because the clinical reality before Foley was a complete mechanical nightmare.
I can't even imagine.
Well, think about it. If a doctor inserted a tube into the urethra to drain the bladder, there was nothing to keep it from just sliding right back out.
Oh, yeah.
So clinicians were literally taping tubes to patients' legs.
Tape. Ouch.
Tape, external straps, or sometimes a nurse just had to stand there and physically hold the tube in place.
That sounds terribly inefficient.
It was. So Foley introduced this remarkably elegant solution. He took a standard rubber tube and added a tiny inflatable balloon near the tip.
So you slide the tube in, you inject a little sterile water to inflate that balloon inside the bladder, and boom, it acts as an anchor.
Exactly. The tube can't fall out.
It's cheap, it's effective, and it completely revolutionized nursing care. Though there is this bizarre historical twist that Foley might not have even held the official patent for it.
Yeah, the manufacturing history is a total mess of lawsuits and competing claims. It's a whole thing.
Right, but the eponym just outran the paperwork.
It totally did. The word of mouth among surgeons and nurses was just too powerful. The adoption of this balloon-anchored tube was so rapid that it universally became known as the Foley.
Because it just worked so well.
Exactly. It solved such a profound daily annoyance for hospital staff that no one cared who owned the patent. They just wanted the device.
And here's the catch. That convenience is exactly what set the trap. Because if we fast forward to 1972, we meet a urologist at the University of Michigan named Jack Lapides.
The foil to Foley.
Yes, He represents the complete opposite philosophy. He was dealing with a deeply tragic patient population, children and adults with neurogenic bladders.
Right, patients with spinal cord injuries or conditions like spina bifida.
Yeah, where the nerve signals to the bladder simply don't work, so they couldn't pee naturally.
And you have to understand, the medical dogma at that time was entirely focused on absolute sterility.
Like keeping everything perfectly clean.
Beyond clean. The prevailing belief was that the bladder was a completely sterile sanctuary. Therefore, any time you accessed it, you had to maintain strict surgical-level sterile conditions.
Gowns, masks, all of it.
Gowns, masks, sterile drapes, the works. So for a child with spina bifida, doctors would often insert a permanent, indwelling Foley catheter to keep the bladder continuously drained. Or they would even perform major surgeries to divert the urine outside the body.
Because they were terrified that if they kept inserting and removing tubes, they'd introduce bacteria, right?
Exactly, that was the fear.
But Lapides looked at the data and realized this permanent sterile tube was actually causing devastating chronic infections. It was causing kidney failure and death.
It was doing the exact opposite of what they intended.
Wait, so the medical establishment thought they were protecting patients with permanent sterile tubes, but they were actually causing the damage. It's like they were treating the bladder as this pristine, sealed vault. But the bladder is actually more like a self-cleaning oven, right?
What's fascinating here is that is the exact mechanism Lapides uncovered.
Yeah.
He had this radical realization that the bladder's natural rhythm, filling up, expanding, and then completely flushing itself out, that is its primary immune defense.
Because the physical rush of urine washes the bacteria away.
Precisely. And the stretching of the bladder wall actually triggers local immune responses. When you place a permanent Foley catheter, the bladder remains constantly empty and collapsed.
So you disable the physical flush and the mechanical immune triggers all at once.
You shut down the whole defense system.
Wow. So what did Lapides tell the medical community to do? Just stop worrying about sterility?
Essentially, yes. Which, as you can imagine, sounded like absolute heresy in 1972.
Oh, I bet.
He introduced clean intermittent catheterization, or CIC. He told patients and parents that they didn't need an operating room environment. They could just wash their hands with normal soap and water, use a clean but not surgically sterile tube, insert it to drain the bladder, and pull it right back out.
And just do this several times a day to mimic the body's natural rhythm.
Exactly.
I can only imagine the pushback from other doctors. I mean, he was basically telling them to break the cardinal rule of infection control.
Oh, the resistance was massive. Surgeons literally accused him of malpractice.
Seriously, malpractice.
Yeah, but the outcomes were undeniable. Lapides proved that periodic flushing of the bladder and removing the foreign object was vastly more protective than trying to maintain permanent sterility with an indwelling tube.
And today, clean intermittent catheterization is the global standard of care for these conditions, isn't it?
It is. It completely changed the field.
Okay, so if a permanent tube breaks the body's natural flushing system, what actually happens inside that stagnant environment?
Well, let's consider the math for a second, because this is the most important number in catheter care. The baseline daily risk of acquiring bacteriuria, which is simply the presence of bacteria in the urine while an indwelling catheter is in place, is roughly 3 to 10% per day.
Wait, 3 to 10% per day, compounded every single day?
Every single day.
So an infection isn't a roll of the dice, it's a ticking clock. If a patient is in the ICU for 3 weeks, it's not just a risk, it's a statistical certainty.
It is virtually guaranteed. By day 30, the colonization rate approaches 100%. It's a matter of when, not if.
Because the catheter basically defeats the bladder's natural flushing mechanism and offers squatters' rights to bacteria.
That's a great way to put it. But they don't just float around in the urine. Within 24 to 48 hours of that tube being inserted, bacteria attach to the plastic or silicone and begin secreting something called an extracellular polysaccharide matrix.
Okay, you're going to have to translate that for me. What on earth is an extracellular polysaccharide matrix?
Think of it as a microscopic, sugary slime shield.
A slime shield. Got it.
Yeah, the bacteria excretes this thick, sticky glue that completely coats the surface of the catheter. This creates a biofilm.
Okay.
And once the bacteria are embedded inside this slime, they undergo a behavioral shift. They start communicating with each other, they share genetic material, and they actually slow down their metabolism.
Like they're hunkering down for a siege.
Exactly. This slime shield is completely impermeable to the patient's immune cells. And much worse, it is highly resistant to antibiotics.
Really?
Yeah, an antibiotic concentration that would instantly kill a free-floating bacterium in a petri dish will just bounce right off a biofilm.
Which means we are dealing with a microscopic fortress.
Right.
I was reading about David Stickler's famous research on this over at Cardiff University, and he highlights a specific bacteria called Proteus mirabilis that takes this fortress building to a terrifying level.
Oh, Proteus mirabilis. It is one of the most destructive organisms you can encounter in a urinary tract, specifically because of how it alters the local environment. It produces an enzyme called urease.
And how does that affect the catheter?
Well, human urine is naturally rich in urea. The urease enzyme secreted by this bacteria breaks that urea down into ammonia.
Okay, and ammonia raises the pH, right?
Exactly. As the ammonia levels spike, the urine's pH skyrockets and becomes highly alkaline. Now, urine also contains naturally dissolved minerals, mainly magnesium and calcium.
Right, normal stuff.
Normal stuff, but those minerals only stay dissolved at a normal, slightly acidic pH. Once the ammonia makes the environment alkaline, those minerals literally crystallize and fall out of the liquid. They form a jagged rock called struvite.
Wait, so this soft, flexible silicone tube is actively turned into a calcified pipe by these bacteria?
Within days, the bacteria incorporate these struvite crystals directly into their slime shield. The biofilm becomes mineralized.
That is just wild.
So very quickly, the inside of the catheter can become completely encrusted and blocked by this bacterial concrete.
That is a plumbing nightmare. I mean, the device that was put in to drain the bladder is now a solid rock blocking the exit.
Right.
The bladder fills up, the pressure builds, and that infected, highly alkaline urine has nowhere to go but backwards, refluxing up the ureters into the kidneys.
And because of that mineralized biofilm, doctors quickly realize you cannot out-medicate this problem. You have to outsmart it. You can pump the patient full of the strongest intravenous antibiotics available, and you might kill the free-floating bacteria, but the ones entrenched in the biofilm will survive.
So if biofilms make bacteria essentially unkillable, it seems obvious we should just change the building materials. I mean, what about technological solutions? We put silver and antimicrobial coatings on everything these days. Why not catheters?
That is a major debate, and it was the biomedical industry's massive push for the last 20 years. The theory was, hey, if you embed silver alloys or antibiotics into the silicone, it will poison the bacteria before they can build their slime shield.
Makes total sense on paper.
On paper, yes, but the clinical reality has been incredibly frustrating. We now have extensive Cochrane-level reviews, which are these massive, rigorous analyses of all available clinical trials, and they show that these expensive, high-tech coatings offer little to no reduction in symptomatic CAUTI or catheter-associated urinary tract infections.
But silver kills everything. Why wouldn't a silver-coated tube stop an infection?
It all comes down to the timeline. The silver might delay colonization by a day or two, perhaps slightly reducing asymptomatic bacteria in the very short term. But biofilms are inevitable. Proteins from the patient's own urine quickly coat the silver, neutralizing its effect entirely.
Wow. So we can't medicate it, and we can't engineer our way out of it with fancy space-age materials. What is the real solution then?
If the problem is duration, the highest leverage intervention is just taking the tube out.
Just take it out.
Yeah. Look at a landmark 2010 systematic review by Jennifer Meddings and Sanjay Saint. They analyzed hospital programs that ignored the high-tech materials and focused purely on human behavior. They implemented simple nurse-driven reminders and automatic stop orders in the electronic medical records.
So, like a pop-up on the screen forcing the doctor to answer, does the patient in bed 4 still strictly require this tube?
Yes. And if the doctor didn't explicitly justify it, the nursing staff had the authority to pull the catheter out. The results were staggering. Just by asking that question daily, hospitals cut catheter days by 1/3, and they halved their CIUTI rates.
Have them. Here's where it gets really interesting. The biggest breakthrough wasn't a silver coating. It was essentially a sticky note asking, does this patient still need this?
Exactly.
But why did doctors need a computer pop-up to remind them? I mean, weren't they paying attention?
Well, it goes back to Foley's balloon. Indwelling catheters were deeply ingrained in hospital culture as a tool of convenience. If a patient is elderly or confused or on diuretics, having a catheter saves the nursing staff from changing soiled sheets or assisting the patient to a bedpan every 2 hours.
I see.
It makes accurately measuring urine output effortless. The device would be inserted in the emergency room and then simply fade into the background noise of the hospital stay.
So it was victim of its own success. It worked so well mechanically that nobody thought about the biological ticking clock.
Yeah.
So what finally broke that culture of convenience?
A massive financial forcing function. In October 2008, the Centers for Medicare and Medicaid Services, or CMS, completely rewrote the rules.
Oh boy, follow the money.
Always. They announced they would no longer reimburse hospitals for the extra costs associated with treating certain hospital-acquired conditions. CAUTI was placed squarely on that list.
Oh, wow. So overnight, a CAUTI shifted from being a routine clinical nuisance that the hospital actually got paid to treat to a massive financial penalty.
It was a tectonic shift. Suddenly, if a patient developed a CAUTI, the hospital had to absorb the cost of the extra days in the ICU, the infectious disease consults, and the expensive antibiotics. That single financial lever changed physician behavior faster than decades of peer-reviewed studies. Hospital administrators cracked down, demanding strict removal protocols and heavily restricting who was allowed to get a catheter in the first place.
But, whenever you tie huge amounts of money to a specific medical diagnosis, you inevitably trigger a massive turf war over how that diagnosis is defined. If I'm a hospital administrator losing thousands of dollars every time a doctor writes CAUTI in a chart, I'm going to argue about what truly constitutes an infection.
And you just hit on the great debate we are still fighting today, the difference between colonization and true infection. Because hospitals are now heavily penalized, the CDC's National Healthcare Safety Network, the NHSN, had to step in and engineer a highly specific definition for public reporting.
And they had to throw out some of the most classic signs of infection to do it, right? I know they dropped pyuria, which is the presence of white blood cells in the urine.
They did, yeah.
If I see white blood cells, my instinct is that the body is fighting an infection. Why drop that from the definition?
Because of the very nature of the device. A catheter is a piece of foreign plastic rubbing against the sensitive mucosal lining of the bladder. That friction causes constant inflammation, and the immune system naturally sends white blood cells to any inflamed area.
Oh, so it's just a physical reaction.
Right? Almost every single patient with a catheter will have pyuria within a few days, regardless of whether they are actually sick. By using white blood cells as a metric, doctors were simply diagnosing the physical presence of a tube, not a bacterial invasion of the tissue.
That makes a lot of sense. So what is the actual strict standard now to call it a true CIUTI?
The catheter must have been in place for more than 2 calendar days. The patient must exhibit systemic symptoms, meaning a fever, chills, or severe localized pain. And finally, you need a urine culture of 100,000 colony-forming units, or CFUs, per milliliter or more.
Meaning if you take a tiny milliliter of urine and put it in a lab dish, 100,000 distinct bacterial colonies will grow from it. That proves a massive bacterial load.
Correct. But the linchpin of that definition is the systemic symptoms, which brings us to the single hardest concept for families and even some clinicians to accept.
Okay, let's debunk the biggest misconception here. Let's paint the scenario. You're visiting your grandfather in the hospital. He has a catheter. You look at the collection bag hanging off the side of the bed, and the urine looks awful. It's cloudy, it's dark, and it smells terrible. Every human instinct screams that he has an infection and needs antibiotics immediately. It feels negligent for the doctor to just walk by and ignore that.
It feels incredibly wrong. But if we connect this to the bigger picture, the Infectious Diseases Society of America, the IDSA, is uncompromising on this point. What you are describing is asymptomatic bacteriuria.
Asymptomatic, meaning no fever, no pain.
Right. There are bacteria in the bag, creating cloudiness and odor, but they have not invaded your grandfather's tissue. The guidelines mandate that asymptomatic bacteriuria in a catheterized patient should never be treated with antibiotics.
Never. Even if the smell is clearing the room.
Even then. Cloudiness and foul odor are a guarantee when you have a biofilm converting urea into ammonia. But if you demand antibiotics based on the look of the bag, you aren't clearing the infection.
Because the biofilm protects them.
Exactly. Treating smelly or cloudy urine without systemic symptoms just breeds antibiotic resistance. You wipe out their good gut bacteria, and you train the bacteria on the catheter to become highly resistant superbugs. You treat the patient's symptoms, not the culture result or the smell.
That is such a vital reframing. Treat the patient, not the bag.
Yeah.
Okay, let's do a rapid-fire debunking of 2 more persistent myths that still cause harm on the hospital floor today. Let's talk about the balloon size. Myth: a bigger balloon over the standard 10 milliliters means a more secure catheter that won't leak.
Fact. That instinct consistently harms the patient. When you overinflate that balloon, it creates a massive, heavy water balloon pressing down on delicate tissue. This causes mucosal irritation and triggers violent bladder spasms as the body tries to expel it.
So it makes it worse.
Much worse. Those spasms actually squeeze urine out around the sides, causing more leakage while simultaneously causing tissue necrosis from the pressure.
Yikes. Okay, next myth: prophylactic antibiotics protect the patient. If we know that compounding daily risk is ticking away, why not just put the patient on a low dose of antibiotics the day the catheter goes in, just in case?
Fact, they just select for resistant organisms. The biofilm still forms, but now it forms exclusively with bacteria that have already proven they can survive your antibiotic. Routine prophylaxis does not protect the patient, it actively endangers them.
Wow, okay. So, pulling all of this together for everyone listening, the narrative arc here went from Frederick Foley inventing a balloon that made it way too easy to leave a tube in out of convenience, to Jack Lapides proving that periodic clean removal is vastly superior to permanent sterility.
Because it always comes back to the ultimate lesson. CIUTI is a duration problem, not a hygiene at insertion problem.
It's the ticking clock.
Yes. The most powerful tool in preventing infection isn't a sterile drape or a fancy silver coating, it's the decision to remove the catheter.
So true. Lapides proved that our obsession with maintaining absolute sterility actually harmed patients, and modern data proves our obsession with leaving tubes in just in case causes inevitable infections.
It's a hard habit to break.
It really is. And it leaves you with a final thought to ponder based on today's sources. It makes you wonder, how many other areas of medicine, or even just our daily life, are we making worse by trying to over-control the environment, rather than just trusting the body's natural rhythms to do the work?
That is a phenomenal question to leave on.
Thanks for joining us on this deep dive. We'll catch you next time.